Good morning, everyone. So this is an important topic because, thank goodness, as we get better and better at diagnosing patients and obviously treating them, we know that we're able to take children who have chronic illnesses, congenital disease, onto the adult population. But one of the things that we haven't been so good at is being able to transition these children and their parents over to the adult side. So we're going to go over in my lecture just a few things that I'd like to point out of areas where each of us in our different areas of the country and our different situations, whether it's a children's hospital or a children's program within a hospital, how we can do a better job, because ultimately the best prepared patient is always better off as far as their outcomes. So we shall begin. These are some of my disclosures. So it's all about raising a child. So this is actually my daughter, just to tell you. So started off as a little pipsqueak, goes on, is a little drama queen, and then winds up going to college and finishes up. And right now she's living in London and has a job, which is great. But it definitely wasn't something, it went from her infancy straight up to the point where she is now, that there was a lot of work that went into her maturity as far as being an independent person, and most importantly, being a self-advocate for herself. So whether it's in her job or whether it's negotiating things, she's actually matured through this process. And in that same vein, the same thing happens for patients who have chronic illness, and the importance of being able to get them to go through the process and mature through it. So it really is about raising a child and taking a village. So clearly our patients don't grow up all by themselves. They have the contribution of their parents, of their family, of their community, and we tend to be the ones that are least pushing them to move on and get into the adult way of looking at things. And some of it is because if you're a pediatrician, you tend to have a different way of delivering medicine, and you tend to deliver it to the entire family versus the patient. And we're going to go over just some distinctions that will make this a little clearer for all of us. What's important to know, as you all know, is that the idea that now that adolescent patients are becoming more and more part of that IBD community, in that it's estimated about 20 to 30% of patients are diagnosed under the age of 18. So that obviously is about a quarter of patients who are diagnosed, and therefore that's the beginning of their disease. And so we have to begin to understand that that process begins at a different maturity and psychological point for many patients, and that between 1991 and 2002, that the annual incidence of inflammatory bowel disease actually increased double. And that we know that Crohn's disease for sure is increasing versus UC, and in the pediatric population, I would tell you about 80 to 85, well, maybe 75 to 80% of all IBD happens to be Crohn's disease. So we know it's going up. UC a little bit less as far as the trajectory goes, but definitely telling you that in our population of children under the age of 21, we're seeing more and more IBD, and therefore it becomes important for us to prepare these patients going forward. So the state of healthcare in the United States, as it is, shows that the prevalence of adolescents between the ages of 12 and 17 with special care needs is about 20%. Less than 50% of the pediatric patients actually are able to have environments where they can be prepared for this next step of going to the adult world. We also know that for pediatric IBD that there are differences in the presentation. For sure, we know that the pediatric behavior is much more aggressive, that in ulcerative colitis it tends to be much more extensive. 80 to 85% of colitis for pediatrics is pancolitis versus what we see for the adult side, which is mostly left-sided. And that the GI tract happens to be more involved in pediatrics than what we see in adults. And the focus that we have specifically is about growth impairment. And I think you all would agree that the time or the window of opportunity to make the greatest impact has to be before puberty. And if you do not get that patient under control after puberty, then you will certainly see growth impairment. So this is an opinion slide of mine, but it's after observation after many years. But the time at which somebody is actually diagnosed with inflammatory bowel disease or any chronic illness becomes a huge determinant in how they will go through the transition process. So if they're diagnosed at a very young age, what happens often is that that patient tends to have a very passive role, that the parent seems to be making most of the decisions, and that the patient, even at the age of 17 or 18 years old, if there's no transition or process, tends to be passive. If it's made in early adolescence, there may be some developmental issues that are going on. They want to struggle for independence. They may not necessarily have the skill sets to be compliant or adherent with their medications, and that may be a significant part of their psychological development. But certainly if it's in late adolescence where they've had the opportunity to mature, they've had the opportunity to struggle with their independence, their reaction may actually be anger, a lot of anger, and the sense that they're angry at the world that they have this diagnosis. They're angry that they can't do the things that they normally do or their peers do. So what are the special considerations? We know that that the treatment needs to be tailored, that the effects of prolonged steroids are not just important as far as growth impairment, but how a patient looks who's on chronic steroids. The question, and this is a big debate that we have in pediatrics, whether monotherapy versus concomitant therapy, whether you need to do both or if there are strategies where you may be able to not do that. Hepatosplenic T-cell lymphoma, which about 10 to 15 years ago became very important as far as consideration goes, has certainly made a big impact as far as pediatrics goes, as far as using thiopurines with any of the biologics. And again, growth is incredibly important, along with psychosocial and sexual development. So transition really isn't leaping from the pediatric office to the adult office. It really is a process that we have to go to, and it's really not the jump. So we'll go over that. So what's the differences in the systems? How is it different that when you're in a pediatric office versus an adult? Well, we know it's family focused. Children come in, they have their mother, they have their father, a grandmother sometimes, other kids. Whereas on the adult side, it's usually just the patient and the doctor in the room. The parents make the decisions for the children, and in the adult side, that adult patient makes that decision. That, again, a patient who hasn't been well prepared may be very passive, versus in the adult, that we expect that that patient's going to be making decisions for themselves. For pediatrics, the appointments may be a bit longer, and again, that may be because it's not just the patient you're talking to, but the entire family. That we're very proactive in pediatrics about pubertal growth and development, that we don't focus that much on fertility and pregnancy, not that it's not important, but it doesn't tend to be the real focus. And often we'll have a multidisciplinary approach. We'll have the nutritionist, the psychologist, the psychiatrist, or even the social worker at that point. And again, for adults, we don't really look at the development, but we do begin at that point understanding that fertility becomes a major part of the discussion, as well as how your disease may impact your employment, and again, less as far as multidisciplinary. So what are the knowledge and the skill sets that we think are important as far as self-management? Certainly you need to name the diagnosis. You have to understand where your disease is. You should be able to name procedures, and this may make sense to the adult world, but these are things that we work on as far as pediatrics. We want to know what the medication dose and frequency, however, that may be a problem, because many patients say, I take a white pill in the morning and I take 2 brown capsules in the afternoon. Drives me a little bananas. You should be able to name who your medical provider is. Often the children don't really have that, so thank goodness they all carry smartphones, and I'm very in their face as far as making sure that they have our office number and how to get in touch with us. But just even the simple thing of making appointments, if you've been a kid that's been sick since the age of 8 years of age, then by the time you're 17 or 18 years old, your mom or your dad may still be making your appointments. The big challenge when they go off to college is, do they understand what their health insurance is? Do they really understand the difference between what medical, outpatient insurance is versus what inpatients? Do they understand what their pharmacy benefits are versus the specialty pharmacies? So these are things that we need to prepare them for. And being able to even refill prescriptions. You can imagine that college student who calls mom up and says, oh, I ran out of my methotrexate. Can you call it into Dr. Sokolow? We really try to make them move along. So the barriers that we see certainly are readiness and maturity. What is their cognitive ability? Because each patient has a different level of being able to understand things. Choice of health insurances. Nowadays, we've been given a little bit of a breather in the sense that children can stay on their insurance of their parents for till about 26 years of age. Let's pray that continues. And that the choices of health providers also becomes quite impactful, because we all understand that it is incredibly important to have a very good, trusting dynamic between the healthcare provider and the patient. So sending my hip teenage, guy who loves rock music off to an older adult gastroenterologist who has no tolerance for people who may be wearing braids or stuff, that is something you have to think about. So you really have to match the patient within that adult provider. So talking about the barriers to successful transition, we know that there's no single model. We know that as far as in the healthcare world now, that there's lack of space and time and adequate support. I think we all see that no matter where you are. Lack of funding. The lack of physician transition healthcare training, and so I thank you for coming today, and hopefully this will be helpful. There are definitely approaches that are different between peds and adult, that there's an inadequate knowledge of insurance coverage for everyone, I would tell you, certainly in the pediatric population, that pediatric gastroenterologists sometimes lack trust of the adult healthcare system because we've been coddling our patients for so long. But in the same direction, the adult world is impatient sometimes when we send them an incredibly immature or ill-prepared patient and family. There is sometimes inadequate communication, and these are important things because if we're going to send somebody off from the adult world to the pediatric world, they really should have the information to the adult side so that they can take good care of patients. And we know that there's a variation in healthcare systems. Again, if you go from a children's hospital to an adult hospital, that's a big leap. If you have a children's program within an adult hospital, but what about community centers? How many pediatric gastroenterologists are there in the country? And do the adult providers seem to take kids when they're younger and younger, depending on the availability of pediatric gastroenterologists? So the barriers that we tend to see most often are really the reluctance and the they don't really want to transfer. And I get that all the time. They say, oh my God, am I really going to have to go to the adult side? We're going to miss you guys so much. And, we sort of give in because we've seen these children. They've been adolescents. We've lived through their college prom. We've lived through them choosing which college they're going to go to. And so there is a reluctance also on the healthcare provider side because we'll miss them. But we know it's important for them to go on. But it's not just the kids, it's the parents, because the parents have been so involved in their child's medical care and they've had a direct relationship with the provider. For the parent to let go of that can be very difficult. But what's really incredibly important, and what is probably the most important, is the patients who tend to have the hardest time at transitioning lack maturity. And so having psychological maturity is probably the key thing. You can you can prepare, but it's really the psychological maturity that becomes the number one thing. So, psychological care, as we said before, if you don't do it well, what could happen? You could have a decreased quality of life, lower self-esteem, social competence, lower rates of clinical attendance, and we know that patients who come often to the outpatient tend to have better outcomes. There's definitely increased rates of depression, and you certainly want to avoid any type of issues where they can't cope. What happens to patients who have poor transition? They could have a delay in their medical care, loss of scheduling follow-up visits, poor compliance with medication, increased emergency room visits, and to me that's a number one disaster because an ER physician is never going to get the totality of what's been going on in the patient's life and may not understand the whole transition issue and what happens with patients, and they have increased hospitalizations. So how do our patients fare? Well, we know that young adult IBD patients tend to lack responsibility for their own care, and that they are not always knowledgeable about their disease, their medication history and medications. Some of them are unaware of the risks of alcohol and cigarettes, and we see that often with our college patients, and that there can be a poor medical and surgical handoff even between providers. So these are things that we know, and that less than 23% of adult gastroenterologists who responded to a survey said that our patients were inadequately prepared for transition. 73% of U.S. adult gastroenterologists report that competency of medical aspects of adolescent care, but only 46% report competency with adolescent development and mental issues. And we're fortunate enough to be having some lectures on that today. So how does an ideal program, how would you say an ideal program could be put together? So most people would say that it's really about staff to develop and implement transition-related support for patients, and that time in clinic to focus on transition becomes number one parameters. So what are the expectations we might look at as far as age? Well, by the time they're 11 to 13, that's certainly in middle school, they should be able to say what their disease is. They should understand the medication that they've been taking, whether it's oral or whether it's injection or rectal medication, even being able to use a thermometer. And they should be able to, at this point, be able to tell you how it affects them, because this is such a crucial age where they have their relationships with their friends, sleepovers, and being in sports, and so you really do want to, even if you have to have the conversation, so how's it going in school? I see that you're on the soccer team. How's that going? I mean, I've had patients who've been on the baseball team who have told me that they played second base but then had to go off because they were having tenesmus and had to run off the field. So these are important things to talk about, even if it's not, directly relating to, how's it going for you. By the time they're 14 to 16, they should know who takes care of them. They should know the names of their procedures. They should understand what their medical history has been about, maybe start thinking about support groups. You understand the risks of if they don't take their medications, what will happen. Between 14 and 16, it's that struggle for independence, and if they say, I don't want to take that medication, you need to be very clear what will happen. And that even though 14 to 16 may seem a little bit early to talk about drugs and alcohol, remember a lot of these patients have older siblings. They go to family parties. Somebody's saying to them, come on, let's go upstairs. We're all going to do shots. And, that could be incredibly difficult for them to go through. And so being able to tell them that that's not a good idea. So I'll just do an aside. So what I say to patients is I have the sex, drug, and rock and roll conversation roughly at about 15 or 16. And I say, first of all, I said, smoking cigarettes is disgusting. It's like picking your nose and eating it in front of the cutest person you ever met. And I said, and the second thing, alcohol. I said, do you ever, fall and skin your knee? And, almost everybody has. Do you ever have, somebody put an alcohol pad on it? Oh, yeah, that hurts, a lot. And I said, well, if you have alcohol, that's the same thing to your GI tract. And I said, so it's a really dumb thing to do, and I think we all would agree patients shouldn't be having alcohol and drugs in their life. By the time they're 17 to 18 or 19 years old, they're going off to college. You want to know that they're able to certainly know about their disease, but they want to be able to gather information. They want to have the ability now at this point to book appointments because they may be off in college. They should be able to fill their prescriptions and contact our medical teams. If many of you may have electronic medical records with a portal system, I tell my patients no matter what time If they have a question, even in the middle of the night, I'd rather them know what the answer to the question is. I tell them I'm not their mother, I'm not their clergy, I'm not their therapist, but I am the person they should ask questions to because I'd rather them understand the outcomes of their decisions. And at that point, too, they should be able to carry their insurance. So everyone has a smartphone, or at least the kids I see in New York, and I say to them, just take a picture or write down what your health insurance is so that if you by chance get into trouble and you need to go to an emergency room, they have all of your information, because kids don't carry wallets, but they always carry their phone. Okay? And then by the time they're 20 to 23, hopefully by this point they've begun to seek out who their adult provider is and hopefully have scheduled an appointment. So there are various tools that are out there that can assess readiness. NASPGHAN, our pediatric society, has put together a checklist. There's IBD Yourself, there's a TRACK, which is another readiness, and then the UNC transition scale. So this is what the NASPGHAN checklist looks like, and you can see there are multiple items. It's not necessarily for the patient to go through each and every time, but it's something that you all may want to look at as different points that you want to make sure that the patient has achieved prior to going to the adult side. This is what the readiness looks like for the TRACK, managing medications, appointment keeping, tracking health issues with all different questions. And again, modern technology, so there are many different apps. Everyone carries a smartphone. There are things like CARA, which is that C up on the top, that can be used for many different chronic illnesses, but it does track different things like your symptoms, your treatments, and your diet. We all know that we have that cloud, and so why do I put the cloud up there? Because if you have a patient who has a chronic illness, just by being able to either carry it on a UCB or taking their health history and being able to put it on the cloud for themselves may be an important way, if they do need to go to the emergency room, how they can retrieve that information for that ER physician. And just being able to have something like on your smartphone a CVS so that you can refill. So when's the right time? So that's the question, the birds and the bees. When do you have that discussion? So you may want to begin that conversation with the families and the patients somewhere between 11 to 14 months of age, because we talk about it. Well, what do you want to be when you get older? Or, what are you thinking of as far as where you're going off to college? So these are natural questions that we ask just about a patient's life. So in that conversation, I would say to you, it's got to be another topic in, what will happen when you finish up college, you'll be going on to an adult provider. I need to make you as prepared as possible so that you can go over to the adult side with the least amount of anxiety. That you want to be able to talk to families about the differences between the pediatric and the adult care. And again, mostly making sure they understand the environment is different. So parents need to let go. They need to make sure that their child is able to have a conversation with an adult healthcare provider, and that they can self-advocate and they can describe any issues that they may have. You may have a tracking form, and so that may be a way just to assess it rather than just having the conversation. And that at some point you really do have to kick the parents out and have that conversation. And so often what I'll say to parents is, at one point I am going to ask you to leave, and sometimes you've got to push them out. But at that point is when you can have a more direct conversation with that now adolescent. So there are some suggestions that we have. So what might you think? So when you're beginning to put this process together, as far as pediatrics go, you may want to have a running summary letter that talks about when they were diagnosed, the location, if there had been hospitalization or surgeries. You certainly want to talk about the health insurance information. You may want to have a calendar or date book to schedule appointments and tests, and important names and contact information, such as your primary care provider, which we as gastroenterologists tend to take a lot of, but what pharmacies, what home health care companies, if that's part of your patient's history, and maybe other subspecialists, because we know that pediatric GI is not the only provider for these patients. They have other issues, derm, ophthalmology, surgery, etc. So it's important to have a collaboration of care. You want to be able to identify in your community who are the adult providers who are not only expert in inflammatory bowel disease, but who is going to be able to relate to that patient and the family. You want to collaborate with the team and understand what they need. What are they looking for? A summary letter? Are you do you have a situation where they can just get into the chart and just read what's going on there? And then sometimes just making that phone call, because we know there are subtleties in taking care of patients that you don't want to necessarily put down in the chart, okay? So overbearing parents or difficult patient who doesn't do things, but these are sort of that quiet way of being able to express that to your adult providers. So there are different options. There are different transition models. You can have joint and pediatric clinics. That's a rarity. You may be able to alternate between having peds one time and adult if a patient's reluctant. But what can sometimes be quite helpful is if they can just have a tour of what that adult office is, or if it's an adult hospital. There's no standard model because there's so many differences in the country. Again, whether it's a children's hospital or a pediatric hospital within a general hospital, different areas of the country have different situations where pediatric healthcare providers are, and that there can also even be a difference between community and an academic hospital. The benefits are that you can have the normalization of development. By having self-management, it means understanding one's own disease, being able to make your own decisions about care, being able to be communicative, scheduling your own appointments, having medical knowledge, and most importantly, self-advocacy. And that improved compliance with the overall transition will come to better outcomes. So, in conclusion, transition is not a transfer of care. It means timing, it means education, it means careful planning, that everyone's adult and pediatric IBD groups should be collaborating to figure out the best way to make this process seamless, and that a well-prepared adolescent IBD patient will turn into a self-advocating and self-confident young adult patient. And that's how I raised those two kids. Thank you very much.